Patient rights, engagement, and safety culture. So, before proceeding with the agenda, we will have a quick introduction about QI, then our today's speaker, then we'll go with the agenda. Then my colleague Ms. Chandra will take care of QI accreditation process. Then later on, we'll take your QI session. Whatever your query and doubts will be take care at the end. So QI is a Quality and Accreditation Institute. It's India's second largest accreditation body. So it's a QI started operation August 2017, and we are fastest development accreditation body in the world because the number of standard which we have developed in total 7 years of operation. So we have developed more than 22 number of standards specifically for the healthcare. So QI accredited body is with the global recognition. For the healthcare facility, we are recognized by ISCO-IEA, and for the ISO standard, we are recognized by APEC and ILAC. So I would like to brief introduction about our founder and CEO, Dr. Bhupender Kumar Rana. He's having more than 25 years of experience into the quality, standard development, accreditation, and patient safety. Earlier, he has been associated with NABH as a former director and CEO in charge, the vertical of Quality Council of India, where his visionary leadership transformed the healthcare quality framework in the country. He is a vice chair of Mutual Recognition Arrangement MRA, the Council of Asia Pacific Accreditation Corporation APEC, founding member of International Academy of Quality and Safety IAPS, member of Scientific Advisory Board International Alliance of Patient Organization IAPO, former board member and chairman of the Accreditation Council of the International Society for Quality in Healthcare ISQA, international expert of the World Health Organization, the World Bank, Asian Development Bank, and the United Nations Framework Convention on the Climate Change, UNFCCC. So we have vision to nurturing the largest global pool of organizations and people through quality improvement and accreditation framework. We have some values. We are good listeners. We are always open for the feedback from the stakeholders. So whatever the stakeholders have query or concerns, we always address their concerns. We are competitive. We look for viable options to benefit users of our services. And QI has adopted transparency because whatever the policies made by QI, they all are available on public domain on our website, qi.org.in. We are innovative. We continuously evolve using co-design and co-creations. We have listened to conceive and deliver education, training, accreditation, and related program in partnership with various stakeholders using an approach of co-design and co-creations. So let's thoroughly go out QI structure. QI having a four verticals, Center for Education and Training, under which we do offer various kind of training as per the ISO standard and other healthcare standards. Then CHSC, Center for Accreditation of Health and Social Care, under which we do offer accreditation for the healthcare service providers. Then we have CIA, Center for International Accreditation, formerly known as the Center for Laboratory Accreditation, so under which we do offer accreditation for the testing and calibration or medical laboratories as per the ISO standards. Then we have Center for Accreditation of Veterinary Facilities, under which we offer accreditation for the veterinary service providers. So let's thoroughly go QI's CHSC accreditation program. So we do offer accreditation for the hospitals, art and IVF centers, ambulatory care, emergency department, vision centers, home care, clinic, stroke centers, patient safety WHO, dental, dialysis, transition care, medical transport organizations, hair transplant, headache clinic, telehealth, BMT, green healthcare facility, and hotel and homestays. So these program standards are developed by QI and the all are program recognized by ISCOA. So recently there is a one more standard introduced by ISO, which is ISO 711. So we adopted this as a 711 plus QI. So for CHSC program, we have international recognition. We become the first accreditation body in India to achieve ISCOA EE accreditation in less than 5 years of operations. And we are the first and only accreditation body in India having two standards accredited by ISCOA. So our CHSC program is recognized by Minister of Health Central Government Scheme Health Scheme, which is CGHS, for the empowerment of private hospital, eye centers, dental centers, and imaging centers. So if you visit CGHS website and in the corner right side, there is a updates. So if you search KI, so the hospital will be listed over there. We are also institutional member of International Society for Quality in Healthcare, ISQA. This is a QI accreditation mark of sustained quality, so which we offer any of the healthcare facility, those who complete QI accreditation process successfully. So let's talk about geographical spread. We are not only limited to India, we have global presence. We have presence in Bahrain, Bangladesh, Ghana, Maldives, Mongolia, Morocco, Myanmar, Nepal, Qatar, Lebanon, Bhutan, and UAE. So these countries, lab or hospital, they already got QI accreditation process. So now I would like to introduce our today speaker. We have very prominent speaker, Akagura Bhattacharya. His area of interest, he is involved in hospital operations, quality assurance, business process, compliance, accreditation, audit, and expansion of department specialties. So he's also associated with the national assessor with the National Quality Assurance System and NQAS, Ministry of Health, Government of India, lead assessor with QI for the hospital stock and IVF standard programs, lead auditor of ISO 9001 for the British Standard Institution, lead auditor ISO 13485 medical device for the British Standard Institution, certified internal auditor as per the ISO 7101 2023 for the management system for quality in health care organizations. Also, technical committee member with QI, former technical committee member of Bureau of Indian Standard, Government of India, former assistant director and conveyor accreditation committee in NABH Delhi, former technical committee member NABH. So currently he is also involved in the project of Department of International Development, Quality Assurance Process Accreditation, TRSCH, New Delhi, Head Quality and Process, SMH, Medical College Noida, State Consultant, WHO IP Global Project New Delhi. So thank you. This is all about today's speaker. So I would like to request Dr. Arka sir to take further. Welcome, sir.
Manish, I'm sharing my screen, okay?
Yeah, please go ahead.
My screen visible?
Yeah, screen is visible. Please share your presentation.
PPT. Yeah. I think it's now visible, right?
Yeah, it's visible now.
Okay. Thanks, Manish. Thank you, Dr. Rana and QI, of course. So we have a long association with QI since their inceptions. And today we are here to discuss about the 7101. That is one of the ISO standards specific of the hospital sector for any size of hospitals, as Manish mentioned in the earlier slide. So the agenda for today is a brief overview of 7101. We will not go to all the details of 7101, but just a brief overview. 7101, like any other application standard these days, 7101 also are very patient-centric standards. We are trying to understand or trying to overview what does it mean by PCC or patient-centric, patient-centered care. Patient safety, obviously, there's a buzzword of today's hospital sector, and of course that also incorporated in that discuss and records requirement. Okay. So as I said, the 7101 was launched in 2023. It's the first international standards in healthcare for quality management of any size of the facility. I think most of you are aware of 9001, 13485, 700, 17025, but they are not specific for hospital. Obviously, the 13485 for the specific for the hospital, but 7101, 2023 is only deals with hospital. So what does it focus? It focuses on patient safety, PCC, that is people-centered care, strong governance, risk management, continuous improvement, strong leadership, co-productions with patients, information security, and aligned to clinical and operational aspects. So this is, if you go to the entire 7101 standard, you will find these components are highly emphasized in the entire standards. So the framework of the 7101, so if you see from clause 4 to clause 10, so the context of the organizations, then it talks about leadership, then it talks about planning. So planning for the hospital, planning for the operational process, planning for the clinical protocols, everything comes under this. Support services are very important component for any accreditations. That is support services. The hospital doesn't only run by a clinical department, but there's a lot of support services involved into this. Then is operations. Hospital operations is one of the biggest challenging components or issue in hospitals. So to my understanding, any other accreditation standards directly don't talks about hospital operations. But fortunately, 7101 that emphasized the entire hospital operational process also. Clause 9, that is performance evaluations, and clause 10 is improvement. When it talks about improvement, so it talks about continual improvement and continuous improvement. So let's come to our first topic of today's webinar. That is how 7101 is a patient-centered standards. Now, if you go through the entire 701 standards, there's a 6 or 7 components they have mentions that indicates these standards is a patient-centered standards. First, if you see the slide, first one, co-productions. Now, when you say productions, it's not very much familiar terms in healthcare. This is more familiar terms in factory assembly lines. But this terminology has been used in 7101. What does it mean by co-productions? They're trying to say that in the entire delivery of healthcare, patients and family should not be a, a, a passive viewer. They should participate actively in the entire care process. That's why I say the co-productions. One side, the hospital and healthcare providers. Other side is patient and family. They should come to a common understanding on a common platform to understand what the hospital or the doctors or nursing team they're supposed to deliver for a particular patient. That's why it's called co-productions. Point two is enhance patient experience. I think some of the very philosopher and industrialists said the patient is the key, the customer is the king. So it is our responsibility as a healthcare providers to enhance patient experience. So there is a lot of way to enhance patient experience. Patient doesn't, it means when the patient even give a call to a hospital for an OPD appointment, or give a call to see a doctor, or give a call to give a blood samples. From that point of time, when the patient come to in contact with the hospital, from that point of time, the experience starts. So it's our responsibility as a healthcare providers to make sure the patients and the families get that experience at each and every touch points. We call it touch points, means when and where the patient is going to avail their services. The OPD is a touch point, the lab service is a touch point, the patient going for investigation, CT, MRI, X is a touch point, patient in the IPD is a touch point. So everything is a touch point. Whenever the patient goes, they should have the great experience in terms of clinical services, in terms of non-clinical services as well. Next is accessibility, as very important components. See, accessibility has two components. First, the patient should have understanding. Patient should understand. Suppose patient is come to my hospital, then how he will reach to my hospital. So that is the first accessibility. Second, when the patient reach a hospital, now the patient want to see an ex-doctor in the OPD. Now the ex-doctor OPD in the building A. Patient don't know how to reach there. So there should be a proper mechanism to assist the patient so the patient can reach to his desired department without much hassle. If so many things, proper the staff of the hospital, the team of the hospital, they should be aware how to respond to the any queries. So that comes under accessibility. Then is equity. So we should not discriminate a patient based on their social strata, financial conditions, and religions or any particular things. There should be unbiased delivery of care, individualist approach. See, from a hospital, in a hospital setup, in administrations, doctors, nursing, is a regular job to serve the patients. But when the patient comes to a hospital, the hospital is not a regular place of work. It's something very new. The environment is very, very new. So they want something very personalized, tailor-made care. So that's why I say that when the patient comes to hospital, definitely we have to follow our protocol, policies, SOPs, everything. But at least when he's sitting or he's lying on the bed taking his treatment, he or she should feel importance that this care is made for mine only. So that feeling, that empathy, we should deliver. Then is information and educations. Now, if you see, we'll come to a more detail of the information and education in the later slides. But these days, patient is so much aware. They come with whole lot of information of any particular disease, any particular conditions. So now is our responsibility also. So whatever the queries they have, whatever disease condition they have, we should give entire information. For example, patient comes with an abdomen pain and a doctor suddenly says, let's go for endoscopy without explaining why he wants endoscopy. The doctor says, let's go for ultrasound without explaining why you need for ultrasound. The information is very, very important to communicate why we are going to give this going for such investigations. Then is continuity of care. The continuity of care means whenever the patient goes, the continuity of care should not break. For example, patient is in ICU and the patient is got shifted from ICU to a step down ward or uh, inpatient. So when the patient getting shifted to a new department, there should not be any discontinuation of treatment. Patient should not lie for 2 hours without any person attending the patients. The proper information from one department to other department should flow. From the patient handover from one department, other department should be given and documented. So the next department also have understanding to what he or she is supposed to do. It also happens in during shift changes. Nurse department, just hold on. Okay. I'm still audible, right? Okay.
Yes, you
So
are
when the
audible.
patient, yeah, so when the patient is during the shift change, the handover is a key components for any department. So there are some tools that we follow, ISBAR, AIDET, and all this. So the entire these components that comprises the entire gamut of patient-centered care means everything that we are doing, the patient should be at the center and at the center point of giving any care. Going to next, that our topic today, that is patient rights. I think most of our working in a hospital, more or less, have an awareness what is understanding of patient rights. And to start with that, patient rights, it's not an accreditation standard requirement. Patient rights have got a lot of medical legal implications. If you are not fulfilling the patient rights at any point of time, you never know that can turn to a medical legal implications. So we have to be very careful to protect the patient rights. Let's talk about this. First is quality care and treatment. That is understood. When the patient is coming to a hospital, it is our responsibility to give a treatment or care that is obviously with the best quality possible for us. Next is tariff list or receipt of information means when the patient come into a hospital, especially I'm talking about private hospital or a corporate hospital where they have to pay for their treatment. So it's a patient rights to know What could be an anticipated treatment cost? See, the accreditations or legalities never say give the patient exact cost. No, it's not possible. In a hospital scenario, it's not possible. But given at least an estimations of what could be the estimated cost of treatment if the patient stay for 3 4 days, if the patient go for surgery or something else. Sometimes exactly pinpointed cost possible, but at least estimations. Now suppose patient admitted in IPD and suddenly condition goes bad and the patient shifted to ICU. So obviously cost of treatment will vary from IPD to ICU. So when the patient is getting shifted to IPD to ICU, the patient is not may not be in a position to understand, but the family member they should be informed about the revised cost of treatment. So that's why we say one is estimated cost of treatment during admissions, and another is revised cost of treatment uh, in case the clinical condition change and any procedure, anything that we have not anticipated but we're supposed to do based on the patient present clinical conditions. Participating in the planning of medical treatment. I think I have discussed in a previous slide that also are somehow the component of co-productions. When the patient comes, we do the initial assessment. We come to a provisional diagnosis. The patient, what is the provisional diagnosis of the patient? Then we go for investigations. So the entire process from the initial assessment, then provisional diagnosis, then if you are planning for investigations, explain to the patient and their families what we are suspecting and why you are going for that particular blood test or particular urine test or particular imaging test or CTMR or whatever. Explain the in the hospital sector, in a hospital scenario, the most disagreement or let's say the lack of communication happens when we don't explain. Because patients, they are laymen, they are not medicals, they are not from hospitals. They don't understand the technicalities. So it's our responsibility to explain. So refusal of treatment is very interesting. See, we have to give the what is our care plan, what are we going to do, what investigation. If you need a surgery, we can propose for a surgery. If you need a procedure, we can propose for a procedure also. So when you're explaining this thing to a family or patient, and if they say no, we are not interested, don't do this. It happens every day in any hospital, in my hospital and your hospital also. That is absolutely patient rights to refuse the treatment. But what we supposed to do to save our skin, we should take that refusal in writing. That is called refusal of treatment, which some hospitals they call is negative consent, whatever you call. But take that refusal in writing that this particular treatment has been offered, but once any sort of reason patient has refused to take that treatment because you never know that could be a detrimental effect in future also. The patient prognosis may hamper, so we should take that consent as well. Right to express spiritual belief, cultural belief, or any individual or family belief. Of course, patient has a unique cultural or spiritual belief that we should respect, provided it's not hampering our our treatment protocol. It's not hampering the comfort of other patients. For example, the patient sometimes comes, especially in ICU, that patient is a very critical conditions that they want to touch a flower or something on their forehead. It's fine. Patient want to put some water for the holy water is fine. That point of time is fine, but patient want to say do something any more than those things, then it may not be in the hospital policy. Then definitely we can say, but a basic spiritual and cultural belief they should respect. We should respect. Very important patient privacy. We should not hamper our patient privacy. That's why we put curtain all around the hospital. If we are doing ultrasound, we put curtain. When we are doing any procedure, even in the ward in ICU, we put curtain. When the patient is OT, we only try to open the incision site only, nothing else. So this ensures the patient privacy. If the patient privacy is not respected, patient can take legal actions. Right to confidentiality. So first we say that privacy, there is confidentiality. Now, if you just break down the confidentiality as a healthcare providers, what is supposed to do? We should not share the patient identity. So obviously, among the care providers, we have to share, but we should not discuss with name with a third person who is not at all connected with the patient or their treatment process about the patient identity. Next is biological information. So that biological information can be patient height, weight, whatever. Any information should not be revealed. Demographic information, patient address. We should not give the patient address to anyone except some people, like sometimes if they have insurance, the insurer may have for any documents. If the patient have a medical legal issue or some that we call medical legal case, then the police or the legal bodies can ask for any details. Then we have to. That is a legal requirement. Clinical information. We should not reveal any clinical information to any third party. Financial information and photography information. See, some of the hospital will take photographs. Even you see the entire hospital, there is CCTV cameras installed across the hospitals. But we suggest that we should not put the CCTV camera exactly on the patient bed. So even in ICU, you can take the footage of the corridors or something, but exactly on the patient bed, it may not be legally accepted because that hampers the patient confidentiality. Some of the hospitals, especially medical college or some big hospital, they have a teaching facility, they have DNVs and all. So in that case, they take video photograph of the surgery. It's okay, that is fine. But for that, we take consent in our surgical consent itself that this particular procedure we are going to have videography evidences for the sole purpose of teaching, nothing else. That we take consent, and if the patient agrees, yes, you can go ahead, then only the videographic evidences are being recorded. Right to consider and respectful care within the recognition of personal dignity. Obviously, personal dignity should not be hampered. We should not speak any false languages. We should respect whenever we communicate. We should give the enough respect. Sometimes in a hospital scenario, sometimes patient get hyper, but we have to be careful because they are going to a trauma, coming to a hospital and never a pleasant experience for anyone, so they may lose their temper. But being in the hospital sector, being in the healthcare providers, we are handling this patient every day. So we should be a bit more respectful. Right to information and get information and educations. As I said in the that patient-centered care. So what they're supposed to do? Obviously, the name of the primary consultant, and if he is being referred for any other consultant, name of the consultant. Diagnosis and treatment. Sometimes we have a notions. Patient will not understand the words of diagnosis. Why he should not understand? He will understand. Please make him or understand in the language. Don't give us medical jargons. So explain in the language they understand. Suppose for a patient having a stone in the kidney, if you say nephrolithiasis, patient may confuse. If you say simple say you have a stone in the kidney, they don't understand. So make your medical term a little bit of layman language and explain them. They'll understand. Alternate course of treatment. Sometimes patient ask that can you go for those treatment, those kind of treatment, any. So if such treatment are available, you may encourage, that is your choice. But if no such treatment is available, you may not encourage. Number one. Secondly, in the same, suppose in the allopathic treatment only, suppose a cancer patients. Suppose cancer patient, they go for surgery, they go for chemotherapy, they go for radiation therapy. So first, if you say suppose you have to go for radiation therapy, then your tumor size would be reduced. Then we can go for surgery. So sometimes patients say, can you go for surgery first? Then you have to explain in the treatment protocol that will not be effective. That we're supposed to say. Expected outcome. If you are doing a procedure, simple procedure, suppose a patient is coming to a respiratory medicine department and doctors want to do a bronchoscopy, right? Bronchoscopy is something that will take the patient to bronchoscopy room. You have to give a local anesthesia, then you have to put your bronchoscope on and all these things. But you have to explain the patient why he has to go through that particular pain. Because when they go to bronchoscopy, obviously some kind of exertion will be there for the patient also. So the outcome of bronchoscopy shall be explained by the treating consultant in detail, so patient gain a confidence to go for the bronchoscopy. Any anticipated emergency. See what whatever we do in a hospital, it has got a side effect. So if you are doing any surgery, it may happen the patient may have a cardiac arrest in the OPT itself. So we have to explain the anticipated. Some emergencies are not anticipated. You just don't expect such things may happen. So, I think someone by one of the hospital, they are doing a orthopedic surgeon, they are doing a orthopedic surgery. Suddenly, patient heart stopped and the patient died on the table. And everything was fine. The PSC was down. There are no abnormalities, and the death cannot be explained. So, this such kind of incidents is unanticipated. But if you are anticipating some kind of emergency, so we also take it's something called high risk consent. If you're expecting excessive bleeding, then you take consent. So we should explain and take high risk consent also. Any plan for referral or transfer, preventive aspect of care. For a patient coming for a COPD, you should explain, and if you come to know the patient is a smoker, so please explain don't smoke. So a patient is after COPD, patient is going home. So please explain, do not take so much fatty food. So those things of preventive aspect should be explained by the treating team or the treating consultant. Informed consent, one of the most important and medical legal implications, I would say, because whenever you are doing any kind of procedure, please take consent. So these days, most of the hospitals, if you go back 10, 15 years back, we had a one consent and we used to take consent for each same consent for all procedures. Now, if you we have as a healthcare, we have evaluated or we have gone through a phase. We have procedure surgery specific consent. For example, we have consent for bronchoscopy, we have consent for endoscopy, we have consent for upper GI endoscopy, we have consent for lower GI endoscopy, we have consent for anesthesia, we have consent for surgery. Now, if you go to more detail, suppose for eye surgery, we have a consent for different procedure. So consent is very important. Now there is some component of consent. Who take consent? If we consider even Indian circumstances, the doctors are only legally accepted to take consent. No one else can take consent. Given by patient, so who can give consent? First preference is, of course, patient. When the patient is not capable enough to give consent, then he's or her inoc, that inoc is next of kin. That is for surrogate consent. When the patient is not capable of giving consent and someone else behalf of the patient is giving the consent, they call surrogate consent. Obviously, in presence of a witness, so we need a signature from the patient or the family member. We need a signature from the doctors doing the procedure, and we need a witness. These three is the mandate, but for a very practical ground, sometimes witnesses are not available. So someone from the hospital also can sign as a witness. We always say that consent must be bilingual. Means it should be at least the, if I consider the Indian context or maybe the English and local languages. Only a single language consent is not accepted. Why? Because the core agenda of taking consent is explain the patient risk and benefit of a particular procedure. Any alternative treatment available? What is the anticipated outcome? What is the expected outcome out of this procedure? So these things have to be explained in a language patient understand. So if you print your consent form in a language that patient do not understand, that might be create some difficulties. But in a scenario where I have two languages consent form and the patient is not conversant with any of them, then we need a help of an interpreter who will translate the consent to the patient language. See, it's not practical to have consent form in multiple languages. So the role of interpreter is critical. Explain the language the patient understand, invasive procedures, special procedure before photography video, and details risk benefit analysis explained through the consensus. Right to be free from mental, physical, sexual, verbal abuse, neglect, or explanation, self-explanatory. So we should not abuse the patient. That is the core message is of this particular statement. We should not abuse the patient. Very important. Any hospital, whatever you do, you are the best hospital at any of locality, but still patient may have a complaint and patient may have grievances. So you should have a mechanism so patient can reach to the right person to express his complaint. So what we do in the hospital, we put name and numbers of the contact person in case of any complaint or grievances that is displayed at reception, displayed in OPD, displayed in every nursing counter, all the strategic locations that possible. So the patient has any complaint. Other than that, obviously we take feedback. We have a complaint register. Most of the hospital, some of the hospital now have here. QR code for launching complaints. So all the methodology now is available. Whatever the best possible for you, you should adopt and you should communicate to the patient. See if you have any complaint. We are trying our level best to satisfy you and to cure you. Still, if you have any complaint, please reach out to us. So this is the patient safety, patient rights components that supposed to we should be taking care. Now the patient safety. I think we all are doing and ensuring the patient safety. Now, if you see the ISO 7101 standards, 8.8.1 to the clause number that talks about patient safety. So let's very quickly just go through the component of the patient safety that is there. First is patient identifications. So we have to have a patient identifications. Usually, what we have patient name and patient UHID, unique hospital ID. Some of the hospitals they have UHID and IP, UHID and OP, whatever. But the number should be unique. This number should not be given to any other patients. So at any particular point of time, if you want to identify a patient, we usually refer this number. For just for the informations, bed number is not a patient identification, mobile number is not a patient identification, patient age, sex is not a patient identification. There should be a unique number, that is called UHID number. Medication safety. Medication safety itself is a very important component. So if I just talk about the steps for medication, what are the steps where the medication safety can be breached? For example, first, prescription error. Doctors write something that is not understandable. Or doctors write something that drugs may not be a contraindicator for the patient because the drug has been taken and the one drug has been prescribed that has already established patient has got an allergy. So such prescriptions can be a prescription error. Next is transcriptions. When from the prescriptions you are converting to a medication chart, you may have a uh, wrong interpretations or wrong transaction. That is the transcriptions error. So after transcriptions, what we do, we go for indenting of the prescription for our pharmacy. So most of the hospitals these days have online. Some hospitals may have offline. So they say indent and all. So when sending the indent maybe offline or online, so we do mistake from instead of one drugs, we order indent the other drugs. So after the indent reaches to the pharmacy, if the indent is wrong, of course the dispensing would be wrong. Now let's consider indenting is correct. The still pharmacy can do a mistake. That is called dispensing error. So after dispensing, patient the drugs come to OR or ICU. Then we administer the drugs. The nurse who is giving the medications can do a mistake. The mistake can be a seven kind of mistake. That is what 7R. Right patient, right dose, right route, and still right documentations and observations. So that can be a mistake. So this every components comes to under medication safety. So medication safety itself is a huge chapter to deal with, but of course one of the very important component of patient safety. Then called surgical safety. So surgical safety it comes from the patient admitted in the hospital. First, what we do a PAC. So in the PAC, we make sure the patient is not taking any drugs 5 days before that have a blood thinner kind of things. Patient has not taken any drugs can be detrimental during the surgery. So we usually ask the patient, have you stopped taking the drugs as you advised? Most of the patients say yes. Sometimes the patient says no, I have not stopped. I have taken it yesterday also. So that time that can be caused as a surgical safety issue also. So after that, we also do that is for site marking. There is for WHO surgical safety checklist, sign in time and time out. So in every component of that particular checklist that comes under surgical safety. Infection control practices. So infection control practices, why this comes under patient safety? There's a lot of component, but most important component which comes under patient safety, that is hospital acquired infections. These days we also call healthcare acquired infections. Previously we used to call it nosocomial infections. So like ventilator associated pneumonia, that is called VAP, uh, uh, clotting, catheter-associated urinary tract infections, ASSI, cervical side infections. If the patients have on the central line, we call central line blast infections. So those things comes under the patient safety point of view under infection control. Infection control. Apart from that, for last couple of years, it was there previously, but for last couple of years, it has come to a it is like a buzzword. All the hospitals is trying to implement, but there are a lot of challenges. That is called antibiotic stewardship program. Even the government of India is very keen to implement antibiotic stewardship program to make sure the patient has reduced the that is called antibiotic resistance because it's a very open secret that we use antibiotics so rampantly without any sometimes without any clinical evidences also. So in the long run, patients may develop antibiotic resistance that could be very harmful for the patient because in future if they need taking antibiotic, that may not work. That can be resistance. So antibiotic stewardship program also very important component of infection control practices. Prevention of falls, pressure ulcer, and thromboembolism. Prevention of fall, it itself is a patient safety goal. So fall can be divided into various categories. So fall can be from the same level. Fall can be from the different level. Some of the hospitals they are doing quality improvement project for the fall to reduce their fall. So there's in number of components that involves for the patient fall. Like so what we do usually, so when the patient comes in the hospitals for IPD for admissions, usually we do a something called fall risk assessment. So there are different tools are available. One of the very common tool that is the MFS, that is MFA, that is the modified fall scales. For the kids, we also do something called Humpty Dumpty. So different fall scales are available. And if we identify the patient is a high risk of fall, then we take special precautions to prevent fall. But having said that, after doing all precaution interventions, still incidence of patient fall happens every month in most of the hospital because some fall is completely non-preventable. But we have to make sure if any fall is preventable, we should make sure the fall should not happen. Pressure ulcer that we call is HAPU, hospital acquired pressure ulcer. Now we have gone to beyond that. Most of the hospital that is called HAPU, that is called KAPU, that is the community acquired pressure ulcer. One is patient admitted in the hospital and they have due to some reasons patient has developed pressure ulcer. That is the hospital acquired pressure ulcer. And for that, we have there is some different nursing tools are available to prevent pressure ulcer. One of the very common tool to assess the pressure ulcer is called Braden scale, right? A CAPU is when the patient is coming with a pressure ulcer. See, here we have nothing to do because we are not, hospital is not responsible to develop a pressure ulcer already before the admissions. But what we make sure, sorry, what we make sure that once there was a pressure ulcer, once you identify that pressure ulcer should not get worsened. That we call the worsening of pressure ulcer in the hospital. So we do monitor, we supposed to do monitor all these things. And I think thromboembolisms. So thromboembolism happens if the patient has a cannula, patient may develop thrombophlebitis. So you have a different level of thrombophlebitis, 1, 2, 3, 4, as per the VIP scoring, right? Visual phlebitis scoring that can be implemented to prevent the thrombophlebitis. Diagnostic safety, see, because in CT is a huge exposure of radiations. So if it's not clearly indicated, we should not advise any patient for go for CT because it has got a huge amount of radiations. Number one, we have to take very extra care when the patient is going for an MRI because MRI deals with magnet and if the patient having implant like implant or a pacemaker kind of things, so we should remove the implant or pacemaker before patient is sending to MRI. But these days, MRI comfortable pacemaker is already has come. Now in the department, we should not use any furniture, including trolleys and wheelchairs, which are not MRI comfortable. Because there are multiple incidents happen even last 10, 15 years where with patients the because non-use of non-MRI furniture, major accidents happen and the patient died. Blood transfusions. So blood transfusion safety. Obviously, we have a cross match. We take consent. We take do the cross matching. Only then we do the administrations. But after that, also the patient may develop that is called blood transfusion reactions. So the hospital is standing policy and preferably the standing policy should be written in the blood transfusion form itself. What the nurse or the on-duty doctor is supposed to do in case they notice any kind of blood transfusion reactions. Usually we give anti-allergy like injection, Avilan, all these things. And obviously after that we send the blood to the blood bank for examinations to check any cause of blood transfusion reaction that has happened. Last is the knowledge and learning and safety. Everything that we have discussed, that we are discussing, we should explain to the patients. And only we can explain to the patients when we have a knowledge of patient safety. So first we should gather a lot of knowledge in patient safety through training, to attending different conferences, through study, through practice, then we should convert this knowledge as far as possible. Not everything not possible for the patient to understand to the patient for their safety. So I am just trying to try because this point have been already been detailed here. I'm just going fast. Last point that we have to do is the patient engagement. Now, patient engagement. I think we have been discussing the same point once again. Engagement means engage the patient in the treatment process, inform them, then engage them. There is a very beautiful, hierarchy how to engage the patient. Just for information, patient is not only engaged when the patient in the hospital. The patient gives a call and say, I have such problem, whom to see. Patient may be confused, whom to see. The person sitting at the call, he or she with that much of technical knowledge can guide or can transfer the call to a right person who can guide the patients. So from that point of view, patient engagement start. Even the patient sitting at home and asking for information. So you should engage the patient giving right kind of information. Now there's a beautiful hierarchy is there how to engage the patients. First, inform. First is inform, communicate, then consult. After giving information, patient will have a lot of queries because the something is hearing for the first time. Then consult, explain in details. When you consult the patients, then automatically patient will be involved in the discussions. So first there is one discussion from your side, then patient has a queries, patient is showing queries and is giving answer. So at a point of time you will reach to reach to situations when the patient has two communications, then the involvement has been built, then collaborative. Now patient will come to will make her mind, make his mind that okay, let's go, whatever being said. That is the way we empower the patient. So this is the kind of patient engagement, in-person engagement, use digital tools, patient educations, proactive communications. So the core point is please inform in a language patient understand and take his approval, take your approval, and then go ahead. That is the only thing of patient approach. Then you get the best outcome. Sometimes it may happen that your treatment is not responding. But since you have explained the patient and their family that this could happen, the patient already made her mind. So that could be another outcome patient may not hear. So, like communication, I said before, the some of the tools are used in communication. AIDE is for mainly for the handover communications. AIDE, while you are introducing yourself to a patient, so this particular tools, knowingly or unknowingly, that you follow, that acknowledge, introduce, durations, explain, and thank you. So at first acknowledge and introduce. Some it very often see in the hospital. Nurse coming to the hospital, patient bedside, giving injection and going back. Doctors coming to the bedside, giving treatment and going back. But not into giving introduction. Who is he? It's very important to give introductions. Can spend some time with the patient, explain, and whenever leaving, say thank you. The smiling face is always a good face. That also will give a kind of relaxation for the patient also. So this is the ISBAR and ISBAR tools explanations. So this is the topic for today. I am not going to more details because I think just for 1 hour topic and only 3 or 4 components of 7101 that we have discussed today. Maybe in future we can discuss more details of 7101. Any questions we can discuss if Manish has time? Thank you. Over to Manish.
Yes, sir. Thank you so much. So now I request my colleague Ms. Chandni to have brief QA accreditation process. Kindly share your PPT.
Is my screen visible?
Yes, visible.
Just a second. So for the accreditation process of QAI 7101 plus, that is based on ISO standard 7101 2023, the organization who wish to accredit themselves with this particular standard have to do the self-assessment of themselves based on the self-assessment toolkit provided by the QAI Secretariat at the time of application package receival. This after that, they have to maintain this particular standard in their organization for a time period of 2 months. Then after 2 months, they have to provide the QA Secretariat with the application form, SAT, documents, and the fee structure, fees for the application. The review, registration, and acknowledgement of the application is done by the QA Secretariat in a time frame of a week. And then the document reviews. Then there is an optional pre-assessment possible for the organization who wish to do a pre-assessment before the final assessment, which can be an on-site, remote, or a hybrid assessment. The assessment criteria varies. Then the organization provide them the QA Secretariat with the dates for an on-site, remote, or a hybrid assessment, followed by a report reviewed including scoring and non-compliances if there are any raised during the particular assessment. The organization is given a time frame to meet the scoring requirements and submit the corrective action for the non-compliances that have been raised in a particular time frame. When once the non-compliances are cleared out, it is the case is presented to the accreditation committee for the validation of scores and acceptance of the corrective actions. Then a issuance of the correct accreditation certificate is done, which has a validity of 3 years. After this, then the organization has to undergo a surveillance assessment, or that can be an on-site, remote, or a hybrid assessment after 15 to 18 months of accreditation. And before the expiration of the certificate, they have to do a renewal 6 months prior to the expiry of the certificate. What are the benefits of this particular accreditation program? For patient, it is enhanced safety and trust that assures that the procedures are done properly, then the qualified professionals, and transparency and right and continuity of care. Now, this particular standard has 9 clauses and 34 subclauses. The scope is as per ISO 7101. The normative references are as per ISO 7101, and the terms of definition are also as per ISO 7101 standard. Now, what are the support available by us? Training on this particular standard is available. There is internal audit program that is available, and the documentation, implementation, and verification program available. In case of any query, one can visit our website that is www.qai.org.in, or just mail us for any query at this particular email ID that is provided on the screen. If anyone has any doubt regarding this particular process, one could just contact us, or have any doubt can just please raise a query.
Thank you, Ms. Andy. Briefing QA accreditation process. Now we are open for your clearing doubts, whether from the ISO standard or accreditation process. You are feel free to ask. You may unmute yourself also if you have any querying doubts related to the ISO standard or QA accreditation process. So if you have not further querying doubts, can we have one group photograph? I request to all the person, please switch on your camera. We can have one to photograph. Are you ready?
Yeah.
Uh, okay, look into the camera, please. Fine. Thank you, everyone. Thank you, sir, for your wonderful session, and thanks to the participant.
Thank you, sir.
Thank you.
Thank you.